committee of AIOS for giving me this opportunity. So not going in the details of pediatric glaucoma, just touching some clinical pearls, which as a practicing ophthalmologist, we should all know that whenever we start thinking about childhood glaucoma, whenever a child approaches to us, basically the first definition which comes in our mind is about that it's a group of severe pediatric conditions which is associated with elevated intraocular pressure and a cupping that leads eventually to permanent blinding condition. So the major challenge is what? The major challenge is basically because the symptoms may be subtle or the various clinical presentations, everything is there. So in all, we can say that to make the diagnosis at the very first go being a confirmatory diagnosis is definitely going to be difficult. So a high index of suspicion is to be noted from the family physician and the parents. Also, we should always keep in mind that the delayed diagnosis of this congenital glaucoma can definitely lead to blindness, which could lead to further emotional and psychological, I can say, burden on the patient's parents. Also, I was listening to the previous talks and everywhere it was said that in childhood, vision is the most important thing and you have to be very, very well cautious about managing the amblyoppias, which is even a most common thing when it comes to the managed congenital glaucoma as well. So simplifying the classification, we can say that it could be a primary, that the pathology is lying in the angle itself, or a secondary where that it could be the some other thing systemic is manifesting into the angle as a secondary cause. So this was the older classification, and when you simplify and you can come to the newer classification which is adopted by the Childhood Glaucoma Research Network, which says that glaucoma can be there, but if you can see this particular box here, you can see that 2 or more of the listed criteria should be there to fulfill and make a diagnosis of congenital glaucoma. Also, it says that there could be a glaucoma or elevated intraocular pressure with non-acquired systemic diseases, non-acquired ocular conditions, or could be acquired systemic as well as the ocular conditions. Now, when we are dealing with a case of congenital glaucoma, the first thing which comes in the role is really the genetic counseling, because only if you know that how important it is when it comes to a consanguinity of marriage or diagnosing the early disease symptom, only then you can screen and make your, I can say, future parents mentally prepared that what they can and how they are supposed to deal with that particular condition. Now talking about the diagnosis and how do we say as affirm that this particular disease is progressing. For that, there is a, we can say, we know that everybody knows that ophthalmos is the commonest presentation of congenital glaucoma. Along with that, the IOP measurement and the optic disc appearance, that is the baseline investigations, are really important. Because in these all particular cases, the IOP, because of the raised IOP, the enlarging corneal diameter, the increasing axial length, and in turn, everything leads to eventually progressive myopia. Again, when you are diagnosing a case or you are examining a case of congenital glaucoma, be sure that all the time the examination is done under the same anesthetic agents for the serial examination. And always when you are treating a child of less than 3 years of age, the corneal enlargement due to raised IOP can be pointed out as the most significant factor. So the serial corneal diameter can be used as your progressive case when the child is less than 3 years. Pachymetry should not be kept in mind because the role of pachymetry in congenital glaucoma is always debatable. Now, gonioscopy, definitely, I know doing gonioscopies in children is a tedious task, but yes, if it's possible, you can be doing it once a year. Appearance of the disc I have already covered. Now, the rapid change in the refractive status and the axial length is something which we should keep in mind when it comes to progression. So, in all, we can say that, okay, whenever we are talking about progression, we have to keep 3 things in mind: the intraocular pressure, the change of the refractive status, and the axial length, along with the corneal diameter if your kid is less than 3 years. Now talking about the primary congenital glaucoma, not going in the details, just saying sharing a clinical pearl. Clinical screening of the current and the future sibling is really important when there is a history of parental consanguinity when it comes to the primary congenital glaucoma. trabecular dysgenesis. We all are aware about it. Is all given in the books that what all happens in the angle in this particular glaucoma, and the treatment of choice is definitely not a medical treatment. It's rarely when it is going to be covered with the medical treatment. Basically, it's a trabeculotomy plus trabeculectomy. Now talking about the JOAG, the presentation, we know that it's after age of 4 years, and the first line of treatment definitely it is going to be a medical treatment, though it is difficult to control medically. So you might go for the trabeculectomy or a shunt devices. Now these are certain conditions where the glaucoma is associated with non-acquired ocular anomalies. I'm having 1 minute. 1 minute is there. So for these things, you have to do a lifelong monitoring is really important. Aniridia, evaluate and see your case systematically because it might be associated with Wilms tumor, and cyclodestruction may be taken as an option. Not talking about the non-acquired systemic conditions, could be a Sturge-Weber, neurofibromatosis or rubella. And again, it was very well said in the previous talk that always whenever you are facing a case of ectopia lentis, please go ahead and examine your case for a homocystinuria and investigate for homocysteine. Acquired conditions, we all know it's been all covered, steroid induced or cataract surgery induced. And last but not the least, because in kids the pharmacokinetics is entirely different, so please teach your patient's parents to go ahead with the punctal occlusion to have the minimum side effects. And surgery, since we have come up with the micro-invasive glaucoma surgery, minimally invasive, so angle surgery is definitely a coming up good option in the cases of childhood glaucomas as well. So it is important in all to prepare your patients and parents, that is, or the caregivers, for a lifelong follow-up and possible future surgeries. Thank you very much.